And thank you for your time this morning. I tried to be creative with our, might not be doing this right. Oh, look, I did. You've seen everything now.
So are there any questions?
I might make some friends that way. We were trying to come up with a title, and herding cats, this is actually the second time I've used that. This time actually I had a choice. The first time I'll report to our Senior Vice President of Medical Affairs, who's a physician that oversees medical staff, credentialing, privileging, all things physician related, as well as quality and research at Mountain States. And for us now, this particular gentleman actually oversees our IT, which is kind of an interesting change in reporting structure, org structure. But the Chief Medical Officer I reported to prior to the one we have now just gave me this title one time to speak to a group of physicians, and I thought, you could have not set me up for failure from the beginning. But it was an opportunity to try to be creative, because one of the things I definitely have learned in my probably at this point 25 years in quality and improvement is that you have to be creative. In order to be creative, it's important to have a safe environment where you can say something that you're a little uncomfortable with because it might be a little bit too outlandish or too out of the box, or it may sound a little crazy, but those are the very ideas that end up with some work becoming the new way of doing things. And I think that I didn't put that on my sheet that I have in here, my slide about the challenges facing healthcare, but that's a challenge facing any organization in any sector. So my own personal experience with that is coming in front of you all, people that I've never met, and talk about something called herding cats, and it might work and it might not. But I've seen enough of those, it might work and it might not, situations work out, that I'm not afraid to do it anymore. So as you go forward into healthcare careers in your future, whatever career that you choose, I would urge you to also take a little chance every now and then and do something that might be a little bit different, because you never know, people might see a little spark of creativity in there and give you a chance. But I did decide to call this Herding Cats. And really what I want to talk about is maintaining quality in an ever-changing world of healthcare, and not just healthcare, but ever-changing world of everything. I always like to go ahead and tell you up front what the objectives are that I have in mind, because the last thing I want is for you to walk out of here thinking that you've wasted an hour, and hopefully you won't feel that way. But one of the ways I can help prevent that is letting you know up front what I plan on talking about. Because when you see herding cats and ever-changing healthcare, you probably, if you're like me, you've already thought, well, she'll probably talk about this and this and this. That might not be at all what I have in mind. So I want to go ahead and tell you up front, and we'll revisit these objectives at the end. And if I haven't covered something thoroughly, or you have some questions, then there'll be a really good opportunity for you to ask them. But by all means, you can ask questions throughout the next 45, 50 minutes. But so by the end of this session, sometime in the next 45 or 50 minutes, you will be familiar with a couple different meanings for herding cats. Understand some common challenges around quality improvement, particularly in healthcare, and then be familiar with a few models and tools that you can use to address some of those challenges. So the meaning of herding cats, which is really my first objective. I actually found this the first time I had to do this presentation. This is an album cover, and I've got two children that are not children, they're adults, and they're probably the same age group as many of you, or most of you. And so I said something about album like 10 years ago, even 10 years ago, and they're like, "Are you talking about a CD, Mom?" I'm like, "Yeah, that's what I'm talking about." But this was a group called a band called Gaelic Storm, and this is an album they had from the early 1990s. But you know what? They had some songs on Titanic, so they're not completely outdated. But that is one of the first things that came up when I looked at herding cats. Just did a search on herding cats, and then there's a lot of different posters out there that you can see different versions. It's always some type of cowboy riding the range, and instead of lassoing cattle or horses, he's trying to lasso cats. And I started thinking, I wonder what they were thinking, what possessed someone to take something as respectful as the American cowboy and put him out there lassoing cats. And I didn't spend a lot of time on it, because I realized there probably really wasn't a whole lot of point in me trying to figure that out. But what I came up with is, the subtitle here is "Ain't a Feeling Like It in the World." I have heard the phrase, "That's about as much fun as herding cats." And I thought, okay, maybe that was a motivation for this one. But if you look at the phrase herding cats, it's one of the things that frequently comes up is something that implies an impossible task. So I think that that's probably more the motivation behind saying it's like herding cats than anything else. But it does imply something that is impossible. So I started thinking, what about cats? Cats, and I just looked for facts about cats. So here's where we get into that thing where you're like, where is she going with this? Maybe she shouldn't have, maybe she went on this side of the stupid idea. But bear with me. So a little bit of cat background. And then this is, very reputable source, Wikipedia. So far I'm sure I'm like 0 and 4 with you guys. But for cat background, they're valued for companionship. And I thought, I'm not a cat lover, I'm not a cat hater, so I'm very middle of the road here politically for everybody. But I can see that because they're always like wanting to crawl in your lap and everything. So valued for their companionship as a cat fact. This one's interesting to me because, in the back of my mind, I'm thinking, how are cats like people? Strong, flexible bodies, quick reflexes, sharp, retractable claws. I'm pretty sure I might work with some cats. Teeth adapted to killing small prey. And I'm like, okay, I should probably not think of it in that terms. Let's think about cats. Let's not think about your coworkers. Can be easily distracted. I actually have that in common with cats. We call it ADD, but they're just cats, and it's okay if you're a cat and you have that problem. Solitary hunters. That made sense to me too because you always see pictures of cats, whether it's a cartoon or it's real, and you have a cat and you watch them, they're like prowling around trying to find a little mouse or whatever it is that they like to hunt. Communicate through vocalization and body language. I was like, okay, somebody was like stayed up too late when they wrote that. But they're talking about the purring, the grumbling, the meows, and then the body language, the different contortions they go into, and then they're, the way that they'll rub up against you with their head. So they actually have a communication method, if you will, because before I looked this up, I was like, well, they don't really communicate. I was thinking about all the ways cats why they couldn't be herded. And they form feral communities, and I thought, okay, well, that's an interesting list of attributes. Where can we go with that in terms of herding cats? And so then I started thinking about these 3 in particular. Those 3 attributes, and I'm really not talking about people, but certainly it does come to mind. These things would be likely reasons that you couldn't be herded. I would think that you couldn't herd cats. This first bullet here was try to look at that. That makes me think you need to stay away from each other. All the cats need to stay as far away as possible or you're going to kill each other. Easily distracted. How in the world could I command enough attention from a cat to actually herd them where I want them to go? Because if you herd something, you're grouping them together and you're moving them in a direction that I have control over. Not that they get to go look at the mouse over here and bark or meow at the dog over here. They have to do what I need to do. And the fact that they're solitary hunters made me think, well, it's each one for their own. I'm after the prize. I refuse to be herded. That's what I'm thinking that cats are thinking. And then I started looking at the other ones, and I thought, well, they're valued for their companionship. Doesn't mean that they like the companionship of other cats necessarily, but they do form close relationships with their owners or their masters or however you want to phrase that. And they communicate, they have a way to communicate, which means they would be interacting with a human being, at least in this case. Doesn't say that they communicate with other cats. I'm sure they do if they need to. And this right here sounds like a really negative attribute, but they form these communities particularly around a source of food. When they need a source of food, they form these communities. And I thought, well, you know what that tells me? If there's a common need or a common goal, then even these folks, cats, that typically are solitary hunters will form communities because they have a common need or a common goal. So see, I am getting a little out there, but I'm trying to bring it right back into the normal world. So then I was like, well, what does really herd mean? Because here's one of my, if I had a soapbox, and actually I need to be honest with you, I've got a lot of them. One of mine is, let's always have a common definition. And it's a personal, I don't even know what to call it, thing. We'll go with thing this morning. It's a personal thing. But it's very, very important in improvement, because if you're really going to take an organization or your responsibility or a process, or for us what we're doing with right now is developing a lot of care models at Mountain States to the next level, whatever that is for our patients, we have to be able to make sure that we're all using the same language. And it can seem like it takes a long time, but if you have a common definition for whatever you're measuring, whatever you're talking about, even the words that we throw out, like I hear the words, well, that's not statistically significant. And smart aleck Tamera wants to go, would you mind doing the calculation for me to demonstrate that? You know, because we tend to say words and we have good meaning, but do we all really know what statistically significant means? Let's make sure we do if that's what we're going to say. And so I know that's like an extreme example to apply to the word heard, but it is a good, I think, an important thing to remember is in quality improvement, when you're having conversations about improvement and change, make sure everybody's talking about the same thing. Because there's actually an activity, we could have done that this morning, I guess I should have maybe thought about that. We run out of time, I'll show you a way to make that point with people without preaching to them and without offending them. It's a really neat warm-up activity called fuzzy meanings. So if I can talk fast enough, we'll get done, I'll show you how to do that. But heard, if you look it up, and this was from Merriam-Webster, a number of animals of one kind kept together. Oh, didn't mean to do that. Wow. You know, I had a little in-service on this, and it just didn't take, did it? Do you ever have a student repeat your class?
Sometimes 3 times a day, the button's going, you get it 3 times in one class.
Yeah, but it can be a number of animals of one kind kept together under human control. That's not sounding too appealing to me. A group of people with a common bond. So I'm like, okay, what's making more and more sense? Maybe you can herd cats, maybe you can herd, maybe we can, this common bond, herd is not a real flattering word, it's kind of offensive. If I want to say I want to herd people, it doesn't sound very good. It's starting to sound a little bit better to me now. So let's talk about some challenges around the quality in healthcare, and with that kind of background and mindset, this is really just one slide that I'm going to talk through, but I'm going to make some connections back to herding cats here in a little bit. Obviously, I was playing a little bit last night. This is just a watch list, if you will, of just some general terms that would describe the challenges around healthcare. And I'm sure that you've studied these, you've read about them, and even if you've been able to avoid studying and reading about them, you've heard about them, even if you don't intend to. When you turn on the radio or you flip through TV or you pull up whatever your news source is. And one is regulatory requirements. These aren't new for healthcare, but they have expanded and gone into so much more detail and complexity that it really is a challenge. It's not so much the volume of regulatory requirements, although that certainly is a challenge within itself. It is the changes that come about with regulatory requirements. Regulatory requirements, for the most part, are meant to ensure the safety of patients. And certainly as Vice President of Patient Safety, I learn about that a little bit more every day. We have accrediting bodies that regulate us to an extent. We have a lot of safety-based organizations that regulate us with TOSHA, OSHA, VOSHA. But the regulatory requirements are a challenge, and they're a challenge because historically, and this is about half fact and half my viewpoint, to be upfront about it, but regulatory requirements, our work, the way that we've designed our work historically, haven't always incorporated the regulatory requirements. So that and the way that we design our work hasn't always, the way we do our work isn't always flexible, ironically. So that when a regulatory requirement changes or a new one is imposed, it's very difficult. We end up, instead of changing the flow or the way that we do our work to make sure we're compliant, we add something to our already existing way of doing work, our process. So we start to feel the burden of regulatory requirements because every time something new comes in, okay, well, you need to do this now, and you need to document here now, in addition to all the things that you're already doing, whatever your role is, whether you're in the lab or you're in the ICU or you're in the OR or you're in admitting. So that, in my mind, is why we view regulatory requirements as a challenge. It's not the requirements themselves because they're intended to provide either standardization or ensure safety or consistency. But it's the way we incorporate them into our work that's created the challenge. Also, data reporting requirements. I deal with this. It's not a stretch to say that I deal with this to some degree on every day. That's also something that falls within my area of responsibility. Healthcare organizations, and right now I'm speaking mostly of inpatient hospitals, but also outpatient as well. There's an enormous amount of data that we have to report, particularly to Medicare and to our accrediting bodies. For Mountain States, for the most part, it's the Joint Commission on the accreditation of healthcare facilities, but we also have HFAP and AOA accredited facilities in Virginia. And it's an enormous amount of data that we report there, to Medicare, to any type of special certification or centers of excellence. And then more and more, the payers or the insurance companies that we depend upon for the bulk of the payment for the services that we provide are requiring data to be reported. And then as healthcare becomes more and more competitive and reimbursement changes, which is a couple bullets down, more and more private and government-backed payers or insurance companies are offering pay-for-performance or incentive programs. If you achieve certain levels of results, then your organization will achieve an extra percentage or a portion of an extra percentage of reimbursement. It's very, very important, and it's becoming more important literally every month to us and to others. And all that requires data to be reported. Publicly available information, it sounds like a really good thing, and I believe that it is. But in order to prepare for that, it's tied very much to the data reporting requirements. We started being required to report data to the government, to Medicare actually, in 2002. And if we don't report a certain subset of data with a certain level of accuracy, and that accuracy level is now 75%, it used to be 80%. I think it should be higher than that. And I'm really proud to say that we've maintained a 98% data accuracy median for the last 4 years. So I feel really good about that. We've never dropped below 75, so that's a good thing. But the data, we started to have to report it in 2002, and if you don't report it, then you're penalized. It doesn't matter what your results are necessarily, but you just have to report it. Now, it matters what your results are. So if you've heard about, in the area of health reform, if you've heard about value-based purchasing, that is the next step of this mandatory data reporting from the early 2000s, then because you're penalized if you don't submit it. And now that all that data is there, there's a huge database that can allow a lot of comparisons and ranking. So if you go to hospitalcompare.gov, you can compare any hospital anywhere on any measure that's both clinical and patient satisfaction. It's really interesting. There's even there's a website called Quality Check now where you can compare hospitals, and you can compare physicians, you can compare nursing homes, and you can compare home health services. So all that data that we had to report has now fed all these comparative databases, and there's more out there. There's the public databases that are Medicare and government run, Joint Commission accrediting body run, and there's also private databases. And we tend to we have an official statement about publicly available data, and I can't quote it exactly, but it is basically they're all out there, and they're all out there so that you can make wiser decisions about your health care and wiser choices about where you want to receive your health care. However, we do support the public databases because they don't have a private interest in the data. So I just kind of want to give you that background as well. We do put our publicly available data out on our website. So if you go to www.msha.com, which is the Mountain States Health Alliance website, on the left-hand side there's a button that says Safety and Performance, and that's a web page that my department supplies and builds. We update it about once a quarter, and it shows each of our facilities' performance in those key clinical measures as well as patient satisfaction as compared to the state average, the national average, and the national top 10%. So that's very, very important to know about, but it not only does it create a significant amount of work for all good reason, it raises the bar for everyone. because you can put your results out there, but it's really hard to explain them to people on a web page. So it does create some challenges. Changes in reimbursement that I've already mentioned, getting reimbursed less and less. Used to be that we were reimbursed if you were in the hospital for 5 days, and I'm oversimplifying this, we would get paid for 5 days of you being in the hospital. And not necessarily always what it cost us to take care of you, but overall we would get paid for your stay. Now we're getting paid based on your diagnosis. So if you have pneumonia, we're going to get paid for 2.5 days, whether you're in there 2 days or you're in there 8. Well, certainly that is motivation for us to standardize the way we deliver care for that pneumonia patient, so that one, we don't have to keep them 8 days if they don't need to be there. And if we standardize care, then we are more likely to be able to manage our costs so that whatever that standard reimbursement is, hopefully is at or better than what it costs us. We can't always say that. We do deliver care and lose money on that, not intentionally. Sometimes it is intentionally because we are a safety net hospital at Johnson City Medical Center and some of our other facilities. But the changes in reimbursement have really put a crunch on facilities and have really motivated hospitals and other caregivers, outpatient locations, to standardize their care in an effort to reduce the cost, reduce waste, and if you standardize care, then you know that you could, if you follow your process, that you're going to be able to come in at or below your reimbursement rates. And Medicare reimbursement rates are the most challenging to meet. And so our goal is to be able to deliver care at Medicare break-even rates, so that if you get paid by a commercial payer, you're going to get paid a little bit more than Medicare. You might have a little bit of money that you can invest in some technology. But if you at least are able to deliver care at that Medicare break-even rate, then at least you're not losing money. And believe me, it's a huge challenge for all of us. Changes in patient expectations. As patients become more savvy with what they can ask for and what they can demand, their expectations are growing, and this is a good thing. It used to be, I heard someone, and I think it was a talk show, I go back and forth to Nashville a little bit more often than I wish sometimes, and I end up listening to a lot of talk shows because I feel like I've heard every station that XM has to offer at this point. So I started listening to talk shows a couple of months ago, and I can't remember who to give credit to, but he was talking about how the world has changed, the way we do business. He was talking in general. And his example was car sales. And I don't know how many of you can relate to this, but he was saying that, it used to be you went to a car lot and you went when they were open, and it wasn't going to be on a Saturday afternoon when you were done because they closed at 3 or whatever, and they certainly weren't going to be open on Sundays. But he said you would go to a car lot and they would show you what they had available and they would tell you the price. And you really didn't get to say, but I really would prefer that in green, and I really want air conditioning, and I'd rather have leather. He said they basically told you what they could give you, and it was like they were doing you a favor to sell you a car. I don't remember that necessarily, but it was I could buy into it the way he was talking about it, the way I could buy into what he was talking about. And he said now, he goes, you can just go on a car lot and you are the king or the queen when you go in there as the customer. He said they come out and they give you food and they'll give you a balloon and there's music playing and they'll let you drive the car all weekend and come back with it. They'll do all kinds of crazy magic with financing and with the price of the car. He said it's really, really changed. And I think the reason that caught my eye was any of you that have been in there's another presentation I use. Actually, this one's brand new, but there's a kind of a standard couple slides that I show sometimes, and it talks about the timeline for quality. And in the 70s and 80s, one of the things I point out that was real interesting to me when I was first learning about improvement was that Deming, who everybody recognizes as, an important figure in quality, and he very much is still. Tried to give his message to America, and we just weren't ready to listen because we had that we're already on top of the world. We pretty much got everything figured out, and if it's not broke, we don't need to fix it kind of mentality. So that message that he had went to Japan, and I'm probably oversimplifying the story a lot, but they listened. And I do recall suddenly all the really, really good electronics, TVs and radios in my time, and later computers, really good, reliable vehicles suddenly were coming from Japan. And if you look at business over time, the United States started losing business. They were not able to compete in global trade like they had been before. And it was all about quality. So this gentleman talking about automobiles and the sale of automobiles and the changes there really clicked with me because of this historical transition in quality in the automobile industry, where the United States really started struggling in the 80s. If you think about it, it was back in the 80s, and we're just now really starting to be able to even compete in our own country. So it's kind of interesting when you look at that. But that all ties back to patient expectations somehow. Sorry about that. But our patients come in now demanding more information, and they have that right, but they recognize their rights and they're exercising their rights. So it's not that healthcare is unwilling or doesn't want to be able to meet those needs, those expectations, and to make sure that we address all their rights. But historically, healthcare, we've basically more or less told people what we think they need to know, and given them information we think they need, and haven't always placed customer relationships up there on the same pedestal that we have the science of healthcare. And so we're needing to do that. And value-based purchasing that I mentioned before, where you're reimbursed based on your performance, 30% of that is patient satisfaction. 70% is your clinical or your quality performance. 30% is patient expectation. So it's definitely in the big time now. It's not just a nice to have experience. The rapid development of technology, very good thing. Certainly helps save lives, saves time, reduces the recovery time in a lot of procedures. It's very expensive. So it's a struggle, it's a challenge to be able to keep up with it from being able to afford the technology with the changes in reimbursement. But by the time you buy a new piece of equipment, there's already something else out, new. And every time you have a new piece of equipment, it is retraining those healthcare providers that use that equipment or that process. So that also is a challenge. Some of the very good things create challenges because of change. Competition for markets. We live in a very competitive, considering the fact that we're not, very urban here. We live in a very competitive healthcare market. And couple that with changes in reimbursement and increasing expectations. You compete for healthcare not just in your region now, but you compete with the Mayo Clinic and you compete with Duke here in Johnson City. You compete because of telemedicine with people across the world. And it's a fine line sometimes, a fine balance, if you will, to balance competition and collaboration. And the balancing of those for the good of the patient can be a challenge to figure out how to do it, not the will to do it, but how to do it. And then the need to reduce costs, which I've kind of touched on already. So there's a number of challenges that are facing healthcare. All the more reason to herd together, if you will, because if you go back to that CAT facts page that was also interesting, I'm sure, for everyone, and I'm going to go back to something that I'm sure somebody somewhere might find offensive, but the whole feral community thing. I'm not saying we need to form feral communities, but the idea that even an animal that normally is a solitary hunter will form communities over a common goal or need tells me, well, we're crazy if we think that human beings can't form collaborations and partnerships around some common challenges. So, that is absolutely the wave of the future. It's not so much what you can just do within your own house or your own hospital. The need for collaborations is critical to address all the challenges. And we've got to do that in new ways. Mountain States is developing an accountable care organization where our focus isn't on the patients that happen to present themselves in one of our offices or our hospitals, but it tasks us with being responsible for the entire population. So that requires us, that doesn't sound like that much of a difference, because our mission and vision statement actually says we want to help the people of our region attain their highest possible level of health. Very compatible with population health management, but that's not the way we're structured. We're organized and structured to take care of patients when they show up, not to take care of an entire community. So it's actually a significant change for us. And it's going to require us to partner and collaborate with organizations that we historically haven't, such as the the Agency on Aging. They've become a very real partner because of our geriatric patients and our aging population. Well, they've always been out there. We've always gotten along just fine, but we've never sat around a table and planned how to take care of a congestive heart failure patient before. I've interact more and more with our director of home health. And I knew her and I knew her name and I saw an email from her once or twice a year, but I've never interacted with her on a weekly basis. So it's a challenge and it's a good thing, but it is a challenge because we're having to change the way we deliver health care. So if I was to give advice, because some of our communications was, what do people need to know that are pursuing a career in public health around quality and improvement, particularly if they're going to be out there, pursuing a career, finding their role, their place in health. You really have picked a good time. And not that you picked the time, because you are where you are and the world is where it is, but I think you have a lot of things going for you because the reimbursement from Medicare, at least, as well as commercial payers, but definitely Medicare, is moving towards population health management. So, what better preparation to have for that than public health? And I don't know, I like to credit our government with foreseeing this back when they very first started mandatory public data collection in the 1999, 2000, 2001. I'm going to go ahead and give them credit for having this vision, this 15 or 20 year vision. But I think it's very fortunate for you because whereas I have to make the transition from hospital versus doctor's office, and then there's everybody else, you can step into it and show people like me a different way of looking at things. So really, I think that you're very well positioned with your background for where healthcare is going. The one thing that I think will make a difference is the ability to facilitate discussions and people, to manage people, if you will, and to have something solid to rely on. Because in a time of significant and very fast change, like healthcare, but the same thing's happening everywhere else. Just healthcare is where we live. I cannot overemphasize the value of having a proven model to work from and the right tools in your toolbox. It took me about 10 years to build some of these, but I can absolutely tell you when I'm not sure what to do, or things are changing way too fast and people have 18 different viewpoints and it's my job to facilitate agreement and find something that we can agree on. Let's go back to that common goal or that common need. I always go back to a model or tool, and when I don't, I end up going back to it later. And I have to learn that lesson every now and then. I've been at it enough years, I know when I'm making a mistake. But I can't emphasize to you enough the value of these models. So the question is, how can we maintain quality in the ever-changing world of healthcare? And I honestly believe that we can follow some very basic steps, but it all relies on having something solid, a structure that you go back to. First, it's important to consider your challenges and identify your advantages. We're all about knowing what our challenges are, but sometimes we get so caught up in that and all the things that we have to overcome or the obstacles that get in our way that we forget what our advantages are. And if you have read any, and I don't know how many of you would have ever read organization's Baldrige application, but you may have, particularly if you're in a quality class. They're out there. You can go to NIST, National Institute of Standards and Technology.gov, click on the link for Baldrige, and these winning organizations put their summaries of their applications out there. They're really, I don't even know that I'd call them summaries. Some of them have removed some results, but it is a full 50-page application out there. One of the first few pages that you'll read, they will articulate to you what their strategic challenges and strategic advantages are and what their core competencies are. That is the solid model that they work from. They know what their challenges are. We can't pretend we don't have them. They know what their advantages are, and they capitalize on their advantages to address their challenges. For Mountain States, we have a very detailed planning process that allows us to use that advantage, something that we do well, And we can use that really good planning process to plan how to attack some of the challenges. We also have a very good improvement process, I'm pleased to say. Everybody knows how to PDCA, and we're taking those skills to the next level and adding even more advanced improvement tools. Well, once we plan around our challenges, we also are equipped to focus on process improvement. So those are two of our advantages. So consider the challenges, but very, very important step, and don't ever skip it, is identify your advantages, because you need to know what you got in your back pocket that you can use to address the challenges. Next is to define and clarify priorities, determine your model, and then follow the model and use the tools. And I've actually already talked about this one, so we'll go to the next page. Excuse me, which is to define and clarify your priorities. Now this might sound like a step you can go through quickly. This is where being able to facilitate conversation and facilitate a group of people reaching consensus is critically important and very difficult. For example, I served as a facilitator for an organization once, and here's their task. It was their leadership team. They were going to agree on who their key customer was. And that seems like a no-brainer. For Walmart, it's the person that comes in with the shopping cart. For Mountain States, it's the patient that comes in the door that needs something. It seems like a no-brainer. We had a discussion, and I wasn't like, I absolutely recognize I probably could have facilitated a little differently. It wasn't because I was doing a really poor job of facilitating. 3.5 hours, and we still hadn't reached consensus on who the key customer of this organization was. And that might sound like, well, what in the world did y'all talk about? It doesn't sound like you did a very good job, Tamera. But this is the first time that this group had really had that question posed to them. Everybody had assumed who the customer was. But think about healthcare. Yeah, the patient's your key customer. But what about their family? When we talk about population health, well, what about the people that haven't gotten sick enough to come to the hospital yet? That's everybody. Suddenly, it's really hard to know who your customer is. And the next question is even more difficult. What are their key requirements? Every patient might want something different, but what can we manage to? What can we boil down to 3 or 4 key requirements or needs? Defining and clarifying priorities is just as difficult. It may be very clear that the hospital or the organization that you end up being a part of wants to maintain their expenses at or below budget. They want to reduce the incidence of MRSA in the community, and they want to increase the awareness around diabetes. Maybe that's what you want to do. Well, you may all agree on that, but then there's going to be people that are going to weigh in other things. And what if it comes right down to it? Which one of those 3 priorities, if you have to sacrifice one for any given project, which one is going to take higher ranking? Those are very difficult discussions, but they're discussions that you have to have. So define and clarify your priorities, because in a time of change and with all the challenges that we have, we're going to need to know, is our priority to keep the doors open? Is our priority to be number 1 in the entire world? Is our priority to go out and improve the health of school-age children or our older population? Doesn't mean you're going to ignore everybody else, but you got to know what your priority focus is. And then determine what model you would use as an organization or as an individual that will allow you to get there. Now, the model doesn't change with the priorities. The model needs to be generic enough that you will use the model no matter what priority you're addressing, no matter what challenge you're trying to overcome. And I'm going to show you the one that we've opted to use that I would think is ideal. And then once you follow your model, it's important within that model, as you're getting into the details, to pull out the right tool at the right time. And you don't have to know everything. You just need to know where to go to get the information. And you can do that through research. You can do that through the way I do, which is just forming the right team. You know, that's valuing diversity to me. Is I'm going to need someone that is going to be able to think about how this is going to impact our frontline team members. So I'm going to bring in this person. I need this person that is really good at creating value stream maps. They're a walk-in toolbox. I'm going to bring them in. This person is going to understand the financial impact of everything we do. I'm going to bring them in. So when I talk about tools, it's really important for you to know what's out there, but you don't have to be an expert. You just need to know when to pull in the right tool and when to pull in the right resource. So let's talk about my favorite model for any type of organization, and this is the one that we use, and it's the one that I personally use, and I use personally to build my department. I've been in my role actually 3 years next week, and I was in a similar role for years before that, but actually vice president, having the areas of responsibility I have, 3 years next week. And I can honestly say the first not 2 years, I don't think I'd still be in the job if I waited 2 years to do anything. First 2 weeks though, I wasn't real sure what I needed to do because I had some areas, policy and procedure, accreditation, and infection prevention that I hadn't had a responsibility for before. Also with that, the chief medical officer I reported to for guidance, that was my direct supervisor, was no longer with the organization. He'd actually been gone 2 months. I didn't have a chief medical officer for over a year. And also, to add a little bit more complexity, I had some folks that were now reporting to me that I was reasonably sure didn't like me and didn't think I was the one for the job. So it was a real interesting time for me, as you can imagine. And I'd like to say that being responsible for business excellence at Mountain States, this is immediately where I went, but it wasn't. It took me about 2 weeks, and then it was kind of like one of those moments I'm like, oh, duh, I'm glad nobody's here to witness this. I'm not even taking my own advice here. But I did wake up in about 2 weeks. It actually, I'll admit, was kind of at a point, I wasn't desperate, but I was like, I really don't know what to do. How am I going to marshal people together, you know, in a world where things are changing really quickly? They've got a new boss. Not sure if they even know me or like me. How are we going to get this together and meet the needs of patients, meet the needs of Mountain States? And I can honestly say this is exactly where I went. So we use this as an organization, and I use it personally when I need a model to figure out what to do. And the more I use it, the more value it has for me. And here's how it goes. I'll speak about this from trying to decide, do I speak about it from a Mountain States perspective or how I used it personally? And I think I'll talk about how I used it personally, but I certainly can give you some other examples if you want. But I start with, when you look at the Baldrige Criteria, this actually is chapter or category 1, and it makes perfect sense to start with 1, although for whatever reason I have this like mental block about that, and I have to start here. And I started realizing that I've probably been conditioned. You know, patient-centered care is a guiding principle of Mountain States Health Alliance and should be of anybody dealing with health. So it makes sense that that's where I start. I thought maybe it was just some little hang-up I had, but it's not. So for me, I had to first identify my key customer. Who's the key customer of quality and patient safety at Mountain States Health Alliance? For me, at the time, it was my key customer. I mean, definitely it's the patient, but for the service I provide, I'm a corporate support for those that are delivering health care. So in those terms, my key customer was the CEO, Chief Executive Officer, Chief Nursing Officer, Chief Medical Officer, and our strategic service unit directors across our system, because they're the ones that are tasked with actually leading the delivery of health care. So that was about 28 people at the time across Virginia and Tennessee. And I realized that I really couldn't go talk to 28 people, but I could reasonably talk to 12 or 13 if I gave myself a month or two. So what I did is I set up some appointments, either 1 to 2 hours, with a cross-section of people. I took a nursing officer from a small facility in Virginia and one from a large facility in Tennessee, a CEO from a Virginia hospital and one from Tennessee, we didn't have any chief medical officers, so there are some appointments I didn't have to have, but some strategic service units like our oncology service line, our cardiovascular service line, et cetera. I talked to some that historically I'd worked very easily with, and some that I'd found it challenging to work with that I thought historically probably weren't a fan of my department and didn't think they were getting their allocation dollars. So that had a cross section. I didn't want to just talk to the people that I was comfortable with, because if I did, I was going to miss the very customers that can make or break the structure I was going to build. So I identified my key customers, I listened to them, and learned from them what they need to deliver excellent health care now and in the future. That is category 3 in the Baldrige Criteria. Who's your key customers and markets? How do you listen and learn from them? And once you learn from them, what are their requirements? What is it that they need? With that information, I was then able to create the vision or the mission, the objectives of my department. And this is where I realized that we had always operated more or less as in a consultative fashion. The chief medical officer I reported to very clearly explained to me that he wanted to create subject matter expertise within quality and patient safety, and then take that subject matter expertise and deliver it to those that ask for it or need it. So we would do a lot of awareness and education. We would do some assessments, and then we would say, let us know if you need more help. And that type of model works very well for a lot of organizations, but what I was learning wasn't really working as well as it could for us. So the vision, the difference, the way that I needed to leave my part of the organization was to make it change away from consultative and go more into a partnership. The subject matter expertise was still very critical, because you're not going to have any credibility as a partner if you don't have some subject matter expertise. And we've got some great people in our area, many of which have come through this program here. But our approach in how we're going to work with folks was going to be very different. My analogy for it is when my basement flooded, I had someone say, hey, I'll come over and help you clean out your basement. And then they gave me some tips on how I could avoid being in that situation in the future. And they even called me in a few weeks and asked me how things were going and did I need any more help. They were consultative, but they actually got in and helped me dry out the basement first. And that's the kind of partners we were going to be. We weren't just going to give the advice and the assessments. We were going to be side by side. We couldn't own it because we weren't going to be there every day, but we were more partners. So that's the biggest difference here. Then, because I knew what our customers needed and wanted, and we had this direction that I had set for the organization, we started creating some very specific objectives to allow us to create this partnership and some specific actions. So we ended up what we had was a operational plan to create these partnerships so that folks would have what they need. And that's the leadership triad of our business model. With that, once we had these plans and these objectives, we knew we needed to have specific processes in place. We needed a surveillance process and a root cause analysis process and a toolkit for infection prevention. We needed a tracer process, an assessment process where we brought people in, the nurses, the pharmacists, the lab technicians, and we together assessed and reviewed charts and processes for compliance to Joint Commission standards. That was a new process. So we had to spend some time designing our processes and the measures that would tell us if those processes work. With that, I then had a very clear idea of the workforce I was going to need based on the process. Not, hey, I need 18 people and they all need to be RNs, and then I'll figure out what to do with them, which is a little extreme, but not really. That's kind of how we go. And I was even in a meeting yesterday with some key leaders, and they were like, well, we need about 4 people. And I was like, well, what are they going to do? Well, they're going to blah, blah, blah. Like, specifically, what are they going to do? Maybe we need 3. Maybe we need 20. How do we know we need 4? And it's very important to design the work before you figure out not just how many, but what capacity and capability do we need. So how do I make sure that we have not only the right numbers, but people with the right skill set? And not just, I've got these credentials, although that's critically important, because if you don't have the credentials, you're not going to make it to the next step. And the next step is, do you have the right values? Do you have the communication skills? Are you willing to not be a subject matter expert consultant? Are you willing to be a subject matter expert partner? And that was some of my hardest decisions. It's very hard to assess, but it makes these processes work, which allows us to achieve our plans, which allows us to achieve this vision and direction, which makes sure that my customers are satisfied. This right here is measurement analysis and knowledge management. When I talked to my customers, that gave me some information so that I could then create the vision. And as we continue to build the plan, that is more information that we can tie to those needs. As we create our processes and start measuring how many assessments did we complete and how's the score trending, that is also feedback to let me know if the plans are working. So this is a two-way arrow. Every single step in here is based on fact and information, and therefore knowledge, because the experience that we add with the information creates knowledge, and it feeds this. When all this is working well, and I'm very pleased to say it's working very well, it took about 14, 15 months to get it going, but it's working very well, we then have good results to show. That, to me, is the best business model you can use for any organization. And it's free, and it's available to you, www.nist.gov, click on Baldrige, and you can download the entire manual. But that is the model we use at Mountain States, and that's the model I use. Now, as I get into process management in particular, this is where the tools become important. Now, I can talk about this on the process level, I can talk about it on the organizational level. Same thing works. You know, if we're gonna have breakfast out here for everybody, who's the customers of that breakfast? Well, the students that are attending. What do we want? Well, we want something healthy because it is public health, but they also might want something sugary and high carb, and they probably want coffee. So you're figuring out the requirements and kind of setting the direction for breakfast. Then somebody had to create a plan. Let's have it out there about 8:15 or so, and let's make sure that we've got a process to restock it. Suddenly we're in here in the processes. Who's going to do that? Well, I don't know who did it, but they did a really good job, and the results are, there you are. I'll shoot her with the laser. I've been waiting to do that, and how anybody just shoot. Well, the results are, look, we all have breakfast, and there's enough variety out there that no matter which customer you are, you probably found something you like. So we can give her some feedback later and tell her that she did a good job. So you can apply this to anything. So it's a good model. It works for anything. So this is something that some of you may have already seen. When I talk about tools and we talk about processes, standardization isn't always a concept that is quickly accepted in healthcare, because healthcare is a science and it requires critical thinking. And sometimes if you don't explain what you mean, I'm going to go back to making sure everybody agrees on the terms, what standardization means, some folks can feel like you're wanting to take away their critical thinking. And that's not the case at all. Think about what you thought about as you drove to campus today. And I don't know what you thought about, but it probably wasn't, you know, take the key in my right hand, put it in the ignition, turn it a quarter turn, you know, put the car in drive or reverse or whatever. You probably thought about, I wish I could sleep. I hope there's good food for breakfast. I've got this test this afternoon. I've got to go to work at 3. How come the radio isn't working well? I mean, you could have thought about all kinds of things. I sure did. I didn't think about driving, to the point, because we have a standardized process for driving that clearly worked because we're all here. Now, there might be some variation. I tend to drive a little fast. Some of you tend to not come to a complete stop at a stop sign. Well, we basically have the same standard process that allows us to be creative. The same thing in healthcare. A standardized process for ordering medication or for taking care of the heart failure patient allows us to use critical thinking skills when the exceptions occur. The standardized process allows us to deliver the same care to everybody at roughly the same cost, and that's what our patients deserve. But when they present an exception or a complication, then the critical thinking skills kick in. So standardization is exactly what we need in healthcare. And this is just something I'm not going to talk about necessarily, but when we have a new process, we get to the point where we're making an improvement in our process and we see our results go up for a while, then we standardize what we do so that that new improved way of doing something becomes our standard way that we do everything. Once we maintain those results for a while, we make another improvement or change or innovation, and then we go through a period of standardization. This is the improvement lines that you want to see. Because you've got to have this leveling off where you have a new standard and decreased variation. Everything's the same, and at that point you can start making changes. If we make changes right and left, we will never get to an even, consistent performance. Now, what are some of the tools, and I'm not going to spend a lot of time on this because we're getting to the time where we need to close out, but one of the values of standardization, then I'm going to talk about 2 tools that can help you get there, is that for us, the word is team members, but this is the folks that are interacting with patients, whether they're assessing patients in the ED, they're starting an IV, they are performing surgery in the OR, or they're giving vaccinations at the health department. This is folks that are interacting at the very front critical lines of healthcare. And if you have standard processes, they're allowed to do that. They own it. They have the authority over the process because you, if you're the leader, have the assurance and confidence that they're following a standardized process and following it clearly so everybody gets the same results. Managers then can focus on removing obstacles so that folks can then improve. And as you can see, frontline, absolutely, to me, in my mind, there would be more dark blue here. But this is a standard model that I've just lifted. But frontline comes up with the ideas for improvement, and frontline managers, middle management, is responsible for removing those obstacles so that you can get the results that we just saw on the graph. Leaders, the senior leaders of the organization, because they have standardization, have the confidence that processes are working well and patients are being taken care of in a consistent fashion with good results. Managers are tasked with removing obstacles, and they've been equipped to do that to support the frontline work. And then leaders then can think about, well, what can we do new now? They're not worried with day-to-day management. They're not even worried with how can we get that extra 1%. They're worried with, not worried, but they're focused on what can we do in 5 years to change the population health of our region, instead of worrying about the bills that weren't dropped or the patient that had 4 sticks to get an IV started. And sometimes that's what we worry about if we don't have standardization. One of the tools that I find that's very simple and very, very helpful, and you can Google this and find all kinds of examples, is called Saipop. When you have a process and it's just not working well, you've got headaches, you can't figure out what the problem is, so you can talk yourself through this and you can write it down on a napkin. Start here. What is the process? And the process might be people are waiting too long in the waiting room. So it's the admitting process in the doctor's office. The input to that is the information to get them registered so that they can see the nurse or the doctor or have the lab test. The supplier of that information is the patient and your systems that allow you to capture the information. The output of that registration process is that the patient is registered, triaged, and you now have the information to put them in the right level of care. And the customer of that, while you might think it's the patient, is really the caregiver, because they now have the information to deliver the health care. It's called Saipop. The example I have here is one that we did with a trauma team at Mountain States, and the process was trauma care services. The inputs to that, and you can see here, are many. There's a lot of inputs into trauma care services and a lot of suppliers. The outputs of trauma care services, the measurable outputs, are things like complications, discharges, ICU length of stay, and the customers are patients, and then different folks that work across Mountain States to deliver health care. This is an important tool to use, and one that I use most often when someone is talking about, we need to improve diabetes care at Mountain States. And this is how I figure out who I need to work with. Here's the process here. What goes into the process and who provides it. Who receives the benefit or the outputs of the process here. And I look at this list, and I look at this list, and I start to build my team. So whenever you have something to improve, I would urge you to think about what happens, what comes into the process, what makes it work, what happens afterwards, and therefore who do I need to involve. It's a very easy tool to use, and it will allow you to make sure you have the right people involved. The other PDCA, Plan, Do, Check Act, Plan, Do, Study Act, very basic improvement approach. This is something we started deploying at Mountain States 9 years ago, and our goal was to make sure everybody was equipped to have some methodology they could go through to improve their work or to work with each other. We now have, we got people excited about it by offering a competition and quality awards. And now we have a banquet every February where we have 600 or 700 people come. We give away over $10,000 in prize money because people are being rewarded for using PDCA. And PDCA, to go through quickly, is Plan, Do, Check, Act. And I'll leave this presentation so you can have the detail. But the next two slides just go into more detail about what we mean by plan. That's describing the current process by using Saipop that I just talked to you about, mapping out your process so you understand it, figuring out what the root causes of the problem are, and there's 3 different tools that we have that we use for root cause analysis, looking at the data to determine where you're starting and where you need to go, and then developing your solution or your action plan. And I won't go through this in detail, but the action plan is critically important to be highly detailed so that if I broke both of my legs, I could hand it off and you could finish the action plan and the process could still be improved. The only other thing I would emphasize real strongly about PDCA is the importance of doing a small test of change so that you can figure out what your improvement, if your improvement is working, and if it's not working, what changes you need to make. And then once you figure out what's working, make sure that you continue to improve. PDCA is never a straight line. It's always a cycle because it's always continuous. So our objectives for today, I'm going to go through these quickly and you have 30 seconds to ask a question, are to be familiar with a couple meanings for herding cats, which probably spent too much time on, but I thought it was cool. It's much more exciting than improvement. Understand some common challenges around quality improvement in healthcare. Most of that had to do with regulatory requirements and changes in reimbursement. And then be familiar with some models and tools to help you address the challenges. It's important to have an overall general model, and I advocate for the Baldrige business model because it'll work for anybody, anywhere. And then to have the right tools in your toolbox. If you just have an improvement methodology as basic as PDCA, you're on the right track. And you can, the improvement tools are free. Go out and Google Saipop, go out and Google root cause analysis. I'm sure you have a lot of experience with some of those already. They're out there. Just pick one that seems like it's going to work and use it. And if not, then I do have business cards here. I'll be more than happy to put you in contact with someone that can help you because we're all about improvement in healthcare, not just at work. So I'd be glad to share whatever we know. And I'm really sorry I talked so long, didn't give you a lot of time, but I'll hang out for a couple of minutes if you have any questions. So.
Thank you very much.